Prostate adenocarcinoma originates from the glandular epithelium of the prostate, the organ responsible for producing seminal fluid. In most men, the disease follows an indolent course, growing slowly for years before causing symptoms. However, a subset acquires aggressive molecular alterations that enable rapid proliferation, invasion of surrounding tissues, and metastasis to bone and other organs. Practically, a 62-year-old man undergoing routine health screening may be diagnosed incidentally when a modest rise in PSA prompts a biopsy, revealing a Gleason 6 tumor that could be managed conservatively. Conversely, a 68-year-old presenting with new-onset back pain might have a high-grade Gleason 9 tumor that has already spread to the lumbar vertebrae, requiring systemic therapy. The clinical description of prostate cancer dates back to early 20th century autopsy series that noted firm nodules in the prostate. The watershed moment arrived in the early 1990s with the introduction of the serum PSA test, which turned prostate cancer from a disease diagnosed primarily on the basis of palpable abnormalities to one that could be detected at an asymptomatic stage. The widespread adoption of PSA screening dramatically increased the incidence of diagnosed cases, especially low-grade, organ-confined tumors, while also sparking debates about overdiagnosis. Over the past 3 decades, advances such as multiparametric MRI, targeted biopsies, and novel systemic agents have further refined both detection and management. Prostate cancer ranks as the second most common malignancy in men worldwide and is a leading cause of cancer mortality, particularly in high-income regions. Early detection through PSA testing and digital rectal examination, DRE, can identify disease while it remains confined to the prostate, where curative surgery or radiation can achieve 5-year survival exceeding 99%. In contrast, metastatic disease carries a 5-year survival of roughly 30%, underscoring the importance of timely diagnosis and appropriate risk-adapted therapy. For example, a 55-year-old with a PSA of 5 nanograms per milliliter and a Gleason 3+4 tumor may be offered active surveillance, whereas a 70-year-old with a PSA of 45 nanograms per milliliter and extensive bone metastases will require systemic hormonal and bone-directed treatments. Hereditary factors account for approximately 5 to 10% of prostate cancer cases. Mutations in DNA repair genes such as BRCA1, BRCA2, and ATM dramatically increase lifetime risk and often drive more aggressive disease phenotypes. The HOXB13G84E variant is associated with early onset prostate cancer in families without a broader cancer syndrome. In practice, a man with a father diagnosed at age 60 and a known BRCA2 pathogenic variant should begin PSA screening in his early 40s, consider magnetic resonance imaging baseline, and possibly undergo more frequent monitoring or earlier biopsy. Genetic counseling can also guide decisions about cascade testing for relatives. Androgens, primarily testosterone, and its more potent derivative dihydrotestosterone, DHT, bind to the androgen receptor, AR, within prostate cells, driving proliferation and survival. The AR signaling axis underpins both tumor initiation and progression. Therefore, androgen deprivation therapy, a DT, remains a cornerstone of treatment for advanced disease. Estrogen plays a subtler role. After menopause, the balance shifts toward relative estrogen excess, which may modestly affect tumor biology. Clinically, a patient receiving luteinizing hormone-releasing hormone agonists will experience serum testosterone suppression below 50 nanograms per deciliter, leading to tumor shrinkage, but also side effects such as hot flashes and loss of bone density, issues that require proactive management. Epidemiologic studies link high-dose ionizing radiation, such as that received during pelvic radiotherapy for other malignancies, to an elevated risk of subsequent prostate cancer. Occupational or residential exposure to certain pesticides and herbicides, for example, organophosphates, carbamates, has also been associated with modestly increased incidence, likely through oxidative DNA damage and endocrine disruption. A practical illustration is a farmer who has handled pesticide concentrates without protective gear for decades and later presents with a high-grade tumor. Occupational health histories can uncover such risk factors, prompting earlier screening in similar cohorts. Dietary patterns rich in saturated fats, red and processed meats, and low in fiber and antioxidants have been correlated with higher prostate cancer risk, possibly via inflammation and insulin-like growth factor pathways. Obesity, measured by body mass index, BMI greater than 30 kilograms per square meter, is linked to more aggressive disease and poorer outcomes, perhaps because adipose tissue secretes pro-inflammatory cytokines and alters hormone levels. Smoking is an independent risk factor for lethal prostate cancer and can impair treatment response. For instance, a 58-year-old man who eats a typical Western diet, smokes a pack a day, and has a BMI of 32 kilograms per square meter may benefit from a structured lifestyle intervention, plant-based diet, exercise program, and smoking cessation to reduce recurrence risk after definitive therapy. Repeated episodes of prostatitis or other inflammatory stimuli create a microenvironment rich in cytokines, reactive oxygen species, and growth factors, which can promote DNA damage and malignant transformation. Histologic studies have identified proliferative inflammatory atrophy, PIA, as a putative precursor lesion. Clinically, a man with a history of recurrent urinary tract infections and persistent pelvic discomfort may undergo MRI, which could reveal focal inflammation. A subsequent targeted biopsy may detect early neoplastic changes, allowing timely intervention. The prostate consists of glandular epithelium, secretory and basal cells, arranged in acini that drain into the prostatic urethra. It is divided into peripheral, transition, and central zones. The peripheral zone houses 70 to 80% of adenocarcinomas, whereas the transition zone gives rise to benign prostatic hyperplasia. Understanding this zonal anatomy guides biopsy strategies. Systematic 12-core sampling targets the peripheral zone, while MRI-targeted cores often focus on suspicious lesions identified there. Loss of the tumor suppressor PTEN results in unchecked PI3K-AKT signaling, fostering proliferation and survival. Approximately 40% of prostate cancers harbor PTEN deletions, which are associated with higher Gleason scores and resistance to androgen-targeted therapies. The TMPRSS2 ERG fusion, present in roughly half of cases, places the oncogenic ERG transcription factor under androgen-responsive control, driving aggressive growth. These alterations can be detected by fluorescence, in situ hybridization, or next-generation sequencing, informing prognostication and increasingly eligibility for targeted trials, such as PI3K inhibitors. Prostate carcinogenesis follows a multi-step model. An initial driver mutation, for example PTEN loss, creates a clonal expansion of atypical cells. Over time, additional alterations such as TP53 loss, AR amplification, or DNA repair defects confer growth advantage, therapy resistance, and metastatic capability. In practice, serial biopsies from a patient on active surveillance may show a Gleason upgrade from 3+3 to 4+3 over 2 years, reflecting acquisition of such secondary hits. Prostate cancer commonly spreads first to the regional pelvic lymph nodes through lymphatic channels. Hematogenous dissemination, primarily via the Batson venous plexus, seeds the axial skeleton, leading to osteoblastic lesions in the spine, pelvis, and ribs. Clinically, a patient presenting with new-onset thoracic back pain is evaluated with a bone scan or PSMA PET, which may reveal multiple sclerotic lesions, confirming metastatic disease and prompting systemic treatment. Approximately 1.4 million new prostate cancer cases are diagnosed annually worldwide. Incidence is highest in North America, Australia, and Western Europe, reflecting widespread PS screening and lifestyle factors. In contrast, detection rates are lower in sub-Saharan Africa and many Asian countries, though emerging data suggest rising incidence as westernized diets and screening become more common. Risk sharply escalates after age 50, with median diagnosis age of 66 years. African American men have a 1.6-fold higher incidence and up to double the mortality compared with Caucasian men, likely due to a combination of genetic susceptibility, socioeconomic factors, and access to care. Geographic variations align with differences in diet, obesity prevalence, and healthcare infrastructure. The introduction of PSA testing in the 1900s produced a surge in reported cases, especially low-risk tumors. Since the early 2000s, mortality rates have gradually declined, about 2 to 3% per year. This decline is owing to earlier detection, improved surgical and radiotherapy techniques, and the advent of effective systemic agents like abiraterone and enzalutamide. Patients may describe a sensation of incomplete bladder emptying, increased daytime frequency, nocturia, or a weak urinary stream. These symptoms stem from prostate enlargement, compressing the urethra, or from tumor infiltration. For instance, a 72-year-old man with a PSA of 12 nanograms per milliliter and a hard nodule on DRE may experience urgency and hesitancy, prompting further diagnostic workup. Visible blood in urine, gross hematuria, or semen, hematospermia, can be an alarming sign, but occurs in a minority of prostate cancer patients. These findings warrant evaluation for other urologic conditions as well, for example infection, calculi. A patient presenting with painless gross hematuria should undergo cystoscopy, ultrasound, and PSA testing to exclude malignancy. Both the disease and its treatments can impair erectile function. Tumor involvement of neurovascular bundles, nerve-sparing radical prostatectomy, and ADT are common culprits. A 60-year-old man undergoing nerve-sparing prostatectomy may still experience temporary ED. Phosphodiesterase 5 inhibitors or penile rehabilitation programs can mitigate long-term dysfunction. Metastatic prostate cancer preferentially creates osteoblastic, bone-forming lesions, which can weaken structural integrity and cause severe pain. Pathologic fractures may occur after minimal trauma, such as a simple fall from standing height. Management includes systemic therapy, ADT, chemotherapy, bone-targeted agents, zoledronic acid, denosumab, and palliative radiation to the painful site. Systemic manifestations arise from cytokine release, metabolic derangements, and cancer-associated cachexia. Unexplained weight loss of greater than 5% over 6 months, persistent fatigue, and loss of appetite may signal advanced disease or treatment toxicity. A patient on second-line chemotherapy who develops profound fatigue should be assessed for anemia, endocrine dysfunction, and nutritional status. PSA is a prostate-derived serine protease measured in serum. Elevated levels can indicate cancer, benign hyperplasia, or inflammation. DRE provides tactile information about prostate size, consistency, and nodularity. Current guidelines recommend shared decision-making for men aged 55 to 69, with consideration of baseline PS, velocity, and family history. For example, a 58-year-old man with a PSA of 4.5 nanograms per milliliter and a suspicious DRE nodule would be referred for multiparametric MRI and possible biopsy. Multiparametric MRI, MPMRI, combines T2-weighted, diffusion-weighted, and dynamic contrast enhanced sequences to detect clinically significant lesions, enabling targeted biopsies. CT is useful for staging nodal and visceral spread. Bone scintigraphy identifies osteoblastic metastases. However, PSM, a targeted PET CT, offers superior sensitivity for both bone and soft tissue disease, detecting lesions as small as a few millimeters. In a patient with rising PS after radical prostatectomy, a PSM, a PET, may localize a solitary pelvic nodal recurrence amenable to stereotactic radiotherapy. Systematic biopsy samples 10 to 12 cores from predefined zones, providing a broad assessment of the gland. Targeted biopsy leverages MPMRI findings to sample suspicious regions directly, improving detection of Gleason greater than or equal to 7 tumors while reducing the diagnosis of indolent disease. A typical workflow: a patient with a PIR-DS4 lesion on MRI undergoes MRI ultrasound fusion, allowing the physician to place a needle precisely into the area of greatest concern. Pathologists assign a Gleason score by adding the two most prevalent patterns, each graded 1 to 5. ISUP grades translate Gleason scores into a 5-tier system. Grade 1, less than or equal to 6. Grade 2, 3 plus 4 equals 7. Grade 3, 4 plus 3 equals 7. Grade 4, 8, and Grade 5, 9 to 10. Higher grades correlate with increased risk of progression and metastasis. For example, a Gleason 4 plus 3 equals 7, ISUP grade 3 tumor has a worse prognosis than a Gleason 3 plus 4 equals 7. Grade 2, because the primary pattern is more aggressive. The TNM system records tumor size/extent, T1 to T4, nodal involvement, N0 to N1, and distant metastasis, M0 to M1. T1 tumors are clinically inapparent, T2 are organ-confined, T3 extends beyond the capsule, T4 invades adjacent structures. N1 denotes regional lymph node metastasis, while M1 indicates distant disease, most commonly bone. Staging guides treatment. A T2N0M0 patient may be curable with surgery or radiation, whereas T3N1M0 often requires multimodal therapy, including a DT. Risk stratification integrates PSA, Gleason score, and clinical stage. Low risk, PSA less than 10 nanograms per milliliter, Gleason less than or equal 6. T1 to T2 tumors are often managed with active surveillance. Intermediate risk, PSA 10 to 20 nanograms per milliliter, Gleason 7, or T2B to C, may benefit from definitive therapy with or without short-term ADT. High risk, PSA greater than 20 nanograms per milliliter, Gleason greater than or equal 8, or T3 to T4, generally requires combined modality treatment, radical prostatectomy, or radiation, plus long-term ADT. These categories help clinicians discuss prognosis and tailor intensity of treatment. Approximately half of prostate cancers harbor ETS family gene fusions, most commonly TMPRSS2-G, leading to androgen-driven overexpression of oncogenic transcription factors. SPOP mutations define a distinct molecular subclass, 10% of cases, characterized by altered ubiquitination pathways and sensitivity to certain DNA damage agents. These subtypes are being explored as predictive biomarkers for response to PARP inhibitors, immune checkpoint blockade, and novel AR degraders. In a clinical trial, patients with ETS fusion-positive disease showed improved progression-free survival when treated with an ERG-targeted epigenetic drug. Rare histologic subtypes deviate from classic acinar adenocarcinoma. Ductal carcinoma presents as tall pseudostratified columnar cells forming papillary structures and often presents with hematuria. It carries a poorer prognosis. Mucinous adenocarcinoma contains abundant extracellular mucin, resembling colonic cancer. Neuroendocrine small cell prostate cancer is aggressive, often arising after hormonal therapy, and requires platinum-based chemotherapy. Recognition of these variants is essential, as they dictate distinct therapeutic strategies. Active surveillance entails regular monitoring, PSA every 6 months, repeat MRI, and periodic biopsies without immediate definitive treatment, suitable for low-risk, low-volume disease. The goal is to avoid overtreatment while maintaining cure rates. Watchful waiting is a less intensive approach for older men with limited life expectancy, focusing on symptom control rather than curative intent. For example, a 67-year-old with Gleason 3+3 disease and a PSA of 5 nanograms per milliliter may enroll in an active surveillance protocol, having biopsies at 1 year and then every 2 to 3 years. Radical prostatectomy, open, laparoscopic, or robot-assisted, removes the entire gland and seminal vesicles, offering a potential cure for organ-confined disease. External beam radiation therapy, EBRT, delivers high-energy photons to the prostate, often combined with short-term ADT for intermediate or high-risk disease. Brachytherapy implants radioactive seeds, I-125 or palladium-103, directly within the gland, providing dose escalation with limited surrounding tissue exposure. Focal therapies, high-intensity focused ultrasound, HIFU, cryotherapy, or laser ablation, target only the cancerous lesion, preserving surrounding tissue and function. Treatment choice depends on tumor stage, patient comorbidities, and preferences regarding urinary and sexual side effects. Androgen deprivation therapy, LHRH agonists or antagonists, antiandrogens, reduces serum testosterone, inducing tumor regression. Chemotherapy, docetaxel and cabazitaxel, kills rapidly dividing cells and improves survival in metastatic castration-resistant prostate cancer, mCRPC. Novel hormonal agents, abiraterone, a CYP17 inhibitor, and enzalutamide, an AR antagonist, further suppress AR signaling. Radiopharmaceuticals, such as radium-223, deliver alpha radiation to bone metastases, reducing skeletal events. Immune checkpoint inhibitors have limited activity except in mismatch repair-deficient tumors. Targeted agents include PARP inhibitors, olaparib and rucaparib, for BRCA a mutated disease, and KT inhibitors for PTEN loss tumors. Metastatic prostate cancer is treated with continuous ADT combined with either chemotherapy, docetaxel, or novel hormonal agents, abiraterone and enzalutamide, as first-line therapy. Bone-directed treatments, zoldronic acid, denosumab, or radium-223, prevent skeletal-related events. In selected patients with limited oligometastatic burden, stereotactic body radiotherapy, SBRT, to metastatic sites can delay systemic progression. A typical regimen for a newly diagnosed mCRPC patient includes a DT, docetaxel every 3 weeks, and bone protective therapy, with PSA monitoring every 4 to 6 weeks to assess response. Combining modalities maximizes tumor control while balancing toxicity. For high-risk localized disease, the sequence may involve neoadjuvant ADT, then external beam radiation, then concurrent ADT for 2 to 3 years. In node-positive disease, radical prostatectomy followed by adjuvant radiation and prolonged ADT is common. The timing of systemic therapy relative to local treatment is tailored based on disease burden, patient age, and comorbidities. Clinical trials are evaluating earlier integration of PARP inhibitors, or AR degraders, into these multimodal pathways. After definitive treatment, PSA is measured every 3 to 6 months for the first 2 years, then annually if stable. A rise greater than 0.2 nanograms per milliliter on 2 consecutive tests suggests biochemical recurrence, prompting imaging, PSMA PET, and possible salvage therapy. Patients on active surveillance have similar PSA intervals, plus repeat MRI at 12 to 18 months. Symptom review, including urinary, sexual, and bone pain assessments, is integral to detect late toxicities or metastatic progression. Epidemiologic data support a diet rich in fruits, vegetables, legumes, and omega-3 fatty acids, and low in red processed meat, to lower prostate cancer risk. Regular aerobic exercise, greater than or equal to 150 minutes per week, improves hormonal balance and reduces obesity-related inflammation. Chemoprevention with 5-alpha reductase inhibitors, finasteride, dutasteride, can reduce incidence of low-grade disease, though they may shift the grade distribution. Men at elevated risk, family history, African American, may adopt these lifestyle measures alongside regular screening. Risk-adjusted screening tailors PSA intervals based on age, family history, race, and prior PSA velocity. For average-risk men aged 55 to 69, biennial testing is common. High-risk groups may start at 40 to 45 years with annual testing. Shared decision-making involves discussing potential benefits, early detection versus harms over diagnosis, unnecessary biopsy. Decision aids such as pictograms showing absolute risk reduction improve patient understanding. Men with a first-degree relative diagnosed before age 65 or carriers of pathogenic BRCA1/2 or a TM mutations should commence PSA screening at age 40, possibly annually, and consider baseline MPMRI. Genetic counseling is recommended to discuss cascade testing for family members. Early detection in these groups often leads to earlier definitive therapy, which can improve survival compared with standard risk cohorts. 5-year overall survival for localized prostate cancer exceeds 99%, reflecting the curative potential of surgery or radiation. Disease-specific survival drops to approximately 30% for metastatic disease. The median overall survival for mCRPC has improved from 18 months pre-2000 to over 36 months in the era of novel hormonal agents and PARP inhibitors, illustrating the impact of therapeutic advances. Higher baseline PSA greater than 20 nanograms per milliliter, Gleason score greater than or equal to 8, T3/T4 stage, and presence of molecular alterations such as TP53 mutation or PTEN loss independently predict worse outcomes. Combining these variables into nomograms, for example CAPRA, Decipher, provides individualized risk estimates. For example, a 68-year-old with PS at 25 nanograms per milliliter, Gleason 4+4, and PTEN loss has a markedly higher likelihood of progression than a similar aged patient with PS, a 6 nanograms per milliliter, Gleason 3+3, and intact PTEN. Radical prostatectomy offers excellent local control and the ability to assess pathological stage and margins, which informs adjuvant therapy decisions. Radiation therapy combined with a DT improves biochemical-free survival for intermediate high-risk patients, compared with radiation alone. In metastatic settings, adding docetaxel to a DT extends median survival by about 2 years. Comparative studies suggest that, for low-risk disease, active surveillance yields similar long-term survival to immediate treatment, but with better quality of life outcomes. Urinary continence and erectile function are the principal functional concerns after treatment. Nerve-sparing prostatectomy and intensity-modulated radiation therapy, IMRT, reduce the incidence of severe incontinence and ED. Pelvic floor muscle training and phosphodiesterase 5 inhibitors improve recovery. Survivorship programs incorporating counseling, physiotherapy, and sexual health specialists help preserve overall quality of life. Comprehensive genomic profiling identifies actionable alterations such as BRCA2 loss, MSI high status, or AR amplifications. Transcriptomic signatures predict aggressive behavior and guide decisions about adjuvant therapy. In practice, a patient with a metastatic tumor harboring a PLB2 mutation may be offered a PRP inhibitor, while another with a R-splice variant expression might receive an AR degrader in a clinical trial. PSMA, prostate-specific membrane antigen, is overexpressed on most prostate cancer cells. PSMA PET-CT provides high-sensitivity detection of metastatic lesions, often identifying disease missed by conventional imaging. The therapeutic analog, Lu-177 PSMA 617, delivers beta radiation directly to PSMA-positive cells, demonstrating overall survival benefit in the VISION trial for patients who progressed after AR-targeted therapy and chemotherapy. Patients suitable for Lu-177 PSMA 617 have documented PSMA-positive disease on PET and adequate bone marrow reserve. Liquid biopsy approaches, including circulating tumor DNA, ctDNA, exosomal RNA, and microRNA panels, are being validated as non-invasive early detection tools. Changes in ctDNA allele frequency can track treatment response and emerging resistance, for example, R-splice variants. Commercial assays such as the prostate cancer antigen 3, PCA3, urine test provide adjunctive diagnostic information, especially in repeat biopsy settings. High-intensity focused ultrasound, HIFU, and laser interstitial thermal therapy, LITT, allow precise ablation of localized cancer foci while sparing surrounding neurovascular bundles. Early phase 2 trials report greater than 90% negative biopsy rates at 12 months, with low rates of incontinence and erectile dysfunction. Ongoing randomized studies compare focal therapy to active surveillance to define long-term oncologic equivalence. Phase 3 trials are evaluating the combination of PARP inhibitors, for example, olaparib with PD-1 checkpoint inhibitors, for example, pembrolizumab in mCRPC patients harboring DNA repair defects. Novel androgen receptor degraders, ProTACS, such as ARV-110, are being tested for activity after resistance to enzalutamide and abiraterone. These studies aim to overcome the ubiquitous resistance mechanisms that limit current AR-targeted therapies. Deep learning algorithms trained on thousands of MPMRI datasets can automatically segment the prostate, detect PIRADS lesions, and assign a malignancy probability. AI-based risk calculators integrate clinical variables age with imaging features to predict Gleason upgrading, aiding decision-making for active surveillance versus treatment. Early validation shows comparable sensitivity to expert radiologists with reduced inter-observer variability.